Hello everyone, welcome to a new IADS webinar. And today we have Dr. Basel AZAR, the teacher of prosthodontics at Palacky University, Olomouc in Czech Republic. He will deliver a presentation today about complications of dental implantology, the prevention and solutions. We would like to really thank him for kindly accepting our invitation for today's webinar, and he can start now.
Okay, hello everybody. To start with, I would like to thank the IADS for organizing this presentation, and mainly Abanop, who is sitting next to me and helping me with the technical part of this presentation. Well, I would like to start something about me, where I come from. I come from, as you see, Syria, a very small city not far from Damascus. It's called Katana. So where actually I come from, I studied dentistry in Damascus. Afterwards, I did maxillofacial surgery in Damascus as well, before moving to the Czech Republic. My family and my beautiful fiance, by the way, are still there in Syria, so I miss them too much. And now I'm living in the Czech Republic, in the eastern part of the Czech Republic, in a city called Olomouc, as you see on the map. Here, actually, I did my PhD in prosthodontics, and now I'm working in the Faculty of Dentistry as well as the faculty hospital. So I do there dental implants mainly, and prosthodontic part, and mainly also on dental implants. Well, to start, as you see, the topic is about complications in dental implantology. It's very important because we really, like, almost on a daily basis, we deal with complications in implant dentistry. And for me, the most important part in dental implantology is the planning of the implants. So when you plan your implants perfectly, you can expect perfect results without complications. So from now on, you will see photos from our practice, from the faculty and from the hospital. Except for this photo, I took it from the internet because I don't do this way of planning. But this is basically the best way, to be honest, like the best way of planning dental implants. It is, but the problem with this is that it is complicated and it is expensive. So this is why we don't use it much. This way of planning involves making CBCT, which is 3D X-ray, where you can plan your implants, as you see on the photo. And then you can do intraoral scanning of the mouth. And afterwards, you combine data from the 3D X-ray and from the intraoral scanning, and to design your surgical guide. This surgical guide will be fixed, as you see, on the teeth, and sometimes also you use like screw to fix it to the bone. And then you will drill through the surgical guide, and you will insert your implants as well through the surgical guide. So this is the best way of planning dental implants. But as I said, it is like expensive and it is somehow complicated. So the way we do it, it is like simple way. We do CBCT, which is basically the 3D X-ray, to choose the diameter as well as the length of our implant. And then we do normal impression, like silicone impression, and send it to the lab where they can make a model, wax up, and they can make simple surgical guide, as you see here. It's basically the same guide like used for bleaching. So it's the same one, but they make a hole through the occlusal surface of the teeth, of the missing teeth, as you see here. And I do not drill through this guide. I basically like drill and then control. I put the parallel pins, as you see here, to see if I am going through the occlusal surface of the missing teeth. Why do we do it this way? Why do we need to go through the occlusal surface? The goal is to have, later on, to have screw-retained prosthesis. Why do we need screw-retained prosthesis? Because we need to avoid cementation, to avoid cementing crowns on the implants. Because we all know that the excess cement could irritate the peri-implant tissues and cause peri-implantitis. So this is why our goal is always to do screw-retained prosthesis without cementation. And for aesthetic reasons, we need the screw to go through the occlusal surface of the crowns, because if it goes buccally, then it will affect the aesthetic part of our work. So this is why it's good to have a guide and to see that the pins that you are drilling through, that the pins or the long axis of the implant is going through the occlusal surface. So this is good for the future loading as well as the aesthetic part, and you will have the screw retained prosthesis. This is an example, as you see, CBCT, which is on the left, which is the 3D X-ray, where I can draw the nerve. For example, I can see how thick the bone in that area and how long is the bone in that area. And then I can accordingly choose the diameter and the length of my implant. You see the surgical part where I can control the direction, the inclination of my implant using the surgical guide to see that the pin is going through the occlusal surface. And in this case, I can guarantee that I will have a screw retained crown later on and not cemented crown. So this is the way we do the dental implants in the faculty or in the hospital. 3D X-ray and simple surgical guide, which is basically a cheap way of doing of planning dental implants. This is another example. As you see here, we can measure the mesodistal space, we can measure the length of bone that we have, and we can also measure the thickness, the buccopalatal or buccolingual thickness of the bone in that area, and accordingly we try to design to choose the diameter and the length of our implant. Now, before starting with complications, I would love to show some fine cases, some good cases where things went well. And then later on, I will show you when things went wrong, yeah, where we started to have complications, and how we try to avoid them and how we try to treat them when they happen. So this is one implant, for example, for the first molar. Good position, as you see, good inclination. So we can make a screw retained crown, no need for cementation. This is the crown screwed in place. You see occlusal, the hole is occlusally, which is very good. It's not affecting aesthetics. After we tighten it in place to the recommended torque by the company, then we cover the screw with Teflon, and then we cover it with flowable composite or normal composite. It's up to you. And in this case, you have nice result because of the nice planning you had before. After a while, this lady, she also lost the first premolar. As you see, the black one, the big fillings, so it broke, and then it was fractured, and then it had to come out, and another implant went there. Again, good planning, good result, screw retained crown, and you have good final result. So this is for one example of good planning and good result, satisfaction for both the dentist and the patient. Another good example, good planning, good position, good inclination of the implant. So screw retained crown, going through the occlusal hole, and you have nice result. Yeah, I will show a few cases about good planning, good results, and then we will start to see the problems, because we see a lot of problems during our work. We do some of the problems. Our colleagues, I receive cases from my colleagues. I do some mistakes, as I told you, and also we receive also from the private sector a lot of complications, and we have to deal with them. Again, good positioning, good planning, screw retention through the occlusal surface. As you see, nice aesthetics. Now she will go to her dentist to make her a crown on the second premolar. We do the implant part, and her dentist does the dental part, the crown on the adjacent tooth. This is my nurse. This is her case. I actually did one implant for her. You see the second premolar, I was trying to convince her to change the crown because it was very old and very, like not fitting properly and doesn't look like aesthetically properly, but she refused. She said, leave it, just do me the implant. I said, okay. Wax up, CBCT, surgical guide, as you see. The pin is going through the occlusal hole, the occlusal surface. Good positioning, good planning. Impression making, screw retained crown through the occlusal surface, and good result. This is the first premolar that we did. The second, she refused to change it, so I left it. But this is our crown on the implant. So nice aesthetic result. Good fit. Again, first molar case, good position, good planning. In this case, in some cases, when we have good stability for the implant, and where you have no augmentation material, for example, membranes or bony grafts or something like complicated, you can directly put the gingival former or the healing abutment. Yeah, it's better when you do it like single phase, when you insert the implant and directly you attach the healing abutment, as you see here. You leave it exposed directly. So this gives time for bony healing and for soft tissue healing at the same time. So you have better results later on. So I prefer, whenever possible, to do single phase implantation. Put the implant, put the healing abutment directly. But in other cases where you have augmentation, membranes, other stuff, we try to close it totally with cover screw and suture, like for primary intention, primary healing, and then to expose the implant after a few months and put the healing abutment. This is the implant with the healing abutment. After a few months, impression making, screw retained restoration. As you see, occlusal hole, screw retained crown. This is the zirconia crown. It doesn't matter. I don't care about the material, but I care about the planning and the screw retention rather than cement retention. And it is there in place. This is the X-ray after fitting the crown. Here's another case. As you see, again, good positioning, good inclination. We have here a little problem, which is the soft tissues. As you see, there is recession on the adjacent teeth, and there is also soft tissue defect in the buccal surface of the implant. We try to convince the patient to have connective tissue graft from the palate to treat the recessions as well as to thicken the area here buccally, but she refused. So we went directly to making the crown. Screw retained crown again, wherever possible. Here is the crown in place, closed with Teflon, flowable composite, and here is the final result. You see, good crown, but the problem is here with the soft tissues. So this is the complication, but she refused to undergo another surgical procedure to thicken the soft tissues. Another case, box up, simple surgical guide. We do not drill through it, we just use the pins. In this case, I use the drills, but usually the parallel pins to see the inclination of the implants. Good positioning. Third implant here, again, good inclination. Screw retention, as you see. on both sides. Here, usually when we have two implants next to each other, we recommend connecting the crowns. We try not to connect teeth to implants. I will show you some failures, some cases, complications regarding connecting teeth and implant. But when you have implant, we try always to connect them together for better mechanical stability of the implants and for better prognosis and longevity. So we connect them and we try to do screw retention. As you see, good fit, and connection of the two crowns. Here I put question, but I think I'm not sure if I ask question if you will be able to answer, because everybody, like, we have people from different parts of the world. So if we will get answers and how long it will take you to answer the question. The question was like, what do you think about this? Which kind of complication took place here in this case? Yeah, I think we will not wait because it will take a lot of time. So we're waiting for the answers. So the thing what happens here, this is also one kind of complication which could happen during implantation or during the basically extraction of teeth or whatever you do. This is happening during injection, when you give local anesthetic, when you apply local anesthetic, when you apply it without aspiration. In this case, I gave mandibular block to do one implant in the lower molar region, but I didn't aspirate, so I injected intravascularly into blood vessels, and so the vasoconstrictive agent goes back to the infraorbital, as you see, region and to the palatal region, and it causes vasoconstriction. As you see here, bleaching infraorbitally and on the palate. This is because I did not aspirate before injection, and to see if there is blood, if I'm inside the blood vessel, and I pushed very quickly. So always, my recommendation, my advice, aspirate before injecting the anesthetic, and also try to inject slowly. So if anything happens, you stop and do not continue with the application. Anyway, but when it happens, you just give it time, and in a few minutes it is away. But it is like stressful for the patient and maybe for you, so better not to do it. This is the same patient, basically, after the recovery from this bleaching, we started the implantation. You see the surgical guide, simple one, CBCT before, nice inclination of the implant going through the occlusal hole. This is the implant going in place. Again, good stability, no augmentation material. Why not to put directly healing abutment? So we put it directly, like single phase surgery. And after a few months, we make a crown in the lower molar region, as you see. Yeah, this is the crown, nice crown. And here is the fit of the crown on the implant. So when you plan properly, you have nice result. First premolar missing in this case, let's see. There is some defect here on the buccal surface, which is normal. Normally, after tooth extraction, most of the resorption, bone resorption, takes place on the buccal side. The palatal usually is no problem, but usually it is on the vestibular or buccal side or labial side. We exposed the area, and we saw that we have enough bone. Of course, on CBCT before, we assessed the bone, but also when you open your flap, you see the bone. So we said, okay, we will put the implants. No need for augmentation, bone augmentation. This is the implant going in place. We have enough bone, and mainly we leave as much bone as possible on the buccal side, because the palatal side, as you see, it's always cortical, no problems with it. So we leave as much bone as possible buccally. Implant in place. Screw retained crown, which is our target always. And as you see here, as I told you, there is defect on the vestibular side, on the buccal side. No need for bony augmentation, but you can take from the palate, you can take from this area, usually premolar region or molar region, you can take connective tissue grafts and try to thicken the soft tissues in this area. So you remove this defect here. Yeah. I told the patient about this. She said, no need for another procedure. I'm happy. I'm satisfied with this result. This is the first premolar. Yeah. Here you need some thickening of the soft tissues around the implant. But she refused. I said, okay, I cannot force you to have the procedure, but in this case, I would do it. Yeah, you see the concavity on the vestibular area. So in this case, we have soft tissue complication. As I promised, now we will see worse and worse complications. So in this case, as you see, we have many complications, many problems with these implants. Yeah, she came to me, this patient, to do prosthetic work on implants. Look at the soft tissues. No keratinized tissue around the implant, you see? It's mucosa, mobile mucosa. Look at the positioning of the implants. Very close to each other. This implant should be somewhere here, and this one should be more here. And the pontic should be in between. Yeah? In this case, like the best planning is to do soft tissue augmentation, bone augmentation if necessary, and implants more like terminally, like here one and here another one. Our goal is to reduce cantilevers as much as possible, because as you see here, look how we have distal cantilever, which is not much recommended, because this is like this cantilever is basically overloading the implants. So this is why we try to avoid cantilevers as much as possible in implant dentistry. If we put the implant here more distally, then this will come in between and there will be no cantilever. But again, it is poor planning. Look at this case. I don't know what the implantologist was thinking about when he did this case. Look how close the implants are to each other. All this space here, and the implantologist comes and puts this implant here. Why not here? I see like bone somewhere here, more than here. I don't understand why he put it like that, close to each other. And look at the soft tissues. No keratinized tissue like here. Here we have more keratinized, and he puts it here where you have no keratinized tissue. Look at the hygiene. Poor hygiene. Look at the vertical bony defect. Bony defect in this area. So millions of problems in this case, and we have to do prosthesis. And we have to try to make something nice for the patient. It's impossible in this case. When I started doing the prosthesis, I told the patient, so it's very difficult to achieve good results, and it's mission impossible. And when I was removing the healing abutment, this one, the whole implant came out, fortunately, which is good basically for the patient, because now he has to go to his implantologist to put another implant here in a better position and further from this implant, and to improve the oral hygiene. So if I start with this case from the very beginning, if it was my patient, I would improve the oral hygiene, first step, improve the soft tissues, take soft tissue graft from the palate, improve the bone, make bony grafts, vertical augmentation, and then put two implants, one here and one here. Try not to put them next to each other. Try to put them like terminal abutments, one as far as possible in the defect, not like in the middle of the defect. Yeah, here one and here another one. So the planning is very poor in this case. Look at this one. Again, poor planning. Look at this mesial implant, how buccally it is going. Too much buccally. Yeah. So what to do in this case? We do cement retained restoration, because it's very difficult. If you make screw retained restoration, the hole will be on the buccal surface and it will affect the aesthetics. So this is why we combined in this case screw retention on the distal one, which is okay, going through the occlusal surface. But this one, it's difficult to make screw retention because it's going too buccally. So we do abutment and then we fix this one We connect it to the screw retained crown, but we fix it with cement on the abutment. Yeah. So, and this is here provisional crowns. They will be replaced by definitive later on. But this is somehow kind of treating this complication, this bad inclination of the implant. Look at this. Again, these are all cases that come to us, to the faculty and to the hospital, university hospital, to treat them. They come, as I told you, from colleagues, from private dentists, or we do like some problems sometimes. So we really see, these are photos from our practice. Look, again, very poor planning, poor positioning, vertical bony defect, soft tissue, no keratinized tissue. Look at the nice keratinized tissue here around the teeth, but look at the poor keratinized tissue around the implants. So with all the movements of the lip and jet cheeks, it's always pulling on the implant and the soft tissues around the implant, and you will have recession and bone resorption on the buccal surface and failure later on the implant of the implant. Also, the hygiene is very difficult when you have mucosa because it's painful. It's not like keratinized tissue. So the hygiene will be poor when you have directly mobile mucosa next to the implant. Again, if it was my case from the very beginning, I would do soft tissue augmentation by taking 3 gingival grafts from the palate. Then I would do bone augmentation vertically. And then I would do 2 implants. And then I would do the crowns or the bridge on the implants. In this case, if it is like this, you can improve a little bit the soft tissues. If you don't want to remove the implants, you can do soft tissue augmentation by adding 3 gingival graft, and then you can do a bridge using pink ceramic to somehow mask the gingival area. But it is not ideal solution. But as I told you, the implants are there. So what to do? Look at this one. Poor inclination. It's going too buccally. And look at the soft tissues. Look at the nice keratinized tissue again near the teeth, and look at the mucosa, mobile mucosa around the implant. Again, what to do in this case? Poor planning, but how to treat it? You can do like radical treatment, so you can remove the implant, put another one with good position and inclination, or if you want to be less aggressive, you can leave the implant, but try to improve the soft tissues around the implant. And this is what we did. I moved the mucosa typically, and I took 3 gingival graft from the palate and attached it to the implant. This is how we take it from the premolar region or from the molar region, it's up to you. And then you have nice barrier of keratinized tissue around your implant. You see the difference, how it was before? It was like, you can see the implant shining through, how the pull is always on the buccal surface of the implant. And look now, a nice barrier of keratinized tissue. The pull is somewhere here now, far from the implant, because this is like a barrier. Yeah? And for the inclination, we can do, you see the nice barrier? For the inclination, we can treat it with cement retention. So we can put abutment and we can cement the crown on the abutment. It's not ideal, but it is somehow a way to treat this poor inclination. But at least we try to improve the soft tissues around this implant. Another case, again, you see what is poor here. The poor thing here is you see the healing abutments are too low. We need higher ones because you see the soft tissues are growing on top of the healing abutments. And again, no keratinized tissue around the implants. So how to do it? Longer healing abutments and move the mucosa apically and do some 3 gingival grafts from the palate again, very nice source. And at least we have some kind of keratinized tissues around the implants, and we improve it in like the prognosis and the longevity of these implants. Again, it was a question for you, but as I told you, it will take a long time. So this is why I think I will answer directly. Again, the same problems you see always, they are repeating. These complications are repeating themselves. Poor inclination and poor soft tissues. Look at the pull. When you move the lip or the cheek, you see how it is pulling on the implants. And look how here, when you have keratinized tissue, attached gingiva, how it is protecting the gingiva. So we need this white, nice keratinized tissue also here around the implant to protect it from bone resorption and recession. So again, how to treat it? The same as I did before. Free gingival graft from the palate and cement retained crown on the implant. This case, this is called sinus lift procedure. We do it for gaining more bone here in the under the maxillary sinus in the posterior region of the maxilla. I extracted one tooth, and during the extraction we had perforation because there was cyst above the tooth, and we had the perforation. So how to treat it? To treat such surgical complication when you have perforation in the Schneiderian membrane, we put collagen membrane to close the perforation. We put bony graft, then we close the area with membrane and sutures. You see the cyst we had before on the tooth before extraction, and this caused the perforation. We had almost no bone before the sinus lift, and after the lift, you see we have enough bone for 2 implants to come that area. Again, our goal is to do always screw retained crowns when you have good planning and to connect them whenever possible for better longevity and prognosis. Other complication, as you see here, look at the bad inclination. You see, you can see it from this side. So it is going too much buccally. Look here. It should be somewhere here, the implant, more palatally, but look how buccally it is going. This is too much buccally. So again, it's very difficult to do screw retained restoration in this case because the hole will be on the buccal surface somewhere here, and it will be unaesthetic. So we do cement retained restoration. We put abutment, and then we cement the crown on the abutment. We delivered the crown. Then after almost 1 year, she came to me back and with a loose crown and abutment. So I removed the crown and the abutment, and look what I see underneath. You see the excess cement? This is what I'm talking about. This is what we hate about cemented restorations. I always try to clean after cementation. I try to clean with super floss, with normal floss, with a probe, with everything. But the cement always breaks and stays there in the soft tissues. And this is irritation for the peri-implant tissues. And this causes peri-implantitis, which is basically resorption of the bone around the implant and failure later on. Again, you see, look how the poor planning, very buccal. This was misunderstanding between me and the technician. He sent me screw retained restoration for this case because I was like always telling the technician, I need only screw retained work, only screw retained, and even for this case, which is contraindication for screw retained, but he sent me screw retained. Yeah, this is bad, of course. You see the hole is going, it should be somewhere here occlusally, but it is because of the bad inclination, it's going too buccally. So as you see, we cover it with composite. The patient said, yeah. I said, I will repeat it. I will make a cement retained crown. She said, no, I just giving me the crown. She doesn't care about aesthetics, as you see, in the anterior region. So she didn't care. But usually it's bad aesthetics because the composite with time will change color, and you will see the line between the ceramic crown and the composite filling here. So this will change color with time, the porous composite, and you will see the difference between them. So this is why it is contraindication in these cases to do cement retention, screw retention. The problems here, again, many problems. Implants in a patient with poor oral hygiene. You can see the plaque everywhere. You see, poor oral hygiene. This is the first problem I see from this side. Look at the caries here on the second premolar. Decay. Again, problem. Look at the inclination of the implant. It's going too vestibularly. Look at the height of the healing former. It is very, of the gingival former, healing abutment. Look at, it is very low. We need higher one. The soft tissues are growing above it. So many complications. What I did for the patient, I said, I will give you provisional restoration on the implant, which usually is screw retained. Always we do the provisionals like screw retained because we need to remove them later on. So screw retained, provisional crown, and I sent him to improve the oral hygiene and to treat the caries and come back to me after a few months. He came back to me with this provisional after a few months, and the caries were treated, the hygiene was somehow improved. He went to visit the hygienist to improve it, and then now it's time to do the definitive crown, the final crown. Soft tissues are healing somehow, better than before, you remember the before, and the oral hygiene and the caries are treated, and now you see it was very poor inclination of the implant. It was going too much buccal or labially. So how to treat it? One technique, like the normal way, is to do cement retain restoration. But if you want to avoid using cementation, you can use this technique, which is basically this abutment, which has two holes. One for the long screw, which will connect the abutment to the implant, and one for this little screw, which will connect the crown to the abutment. So I screw the abutment in with the long screw, and then I screw the crown to the abutment with this little screw. In this case, the hole is made palatally, so it's not anymore on the labial side, even though the implant was going too labially. You see, no hole is on the labial side. So this is one technique to avoid the use of cementation in such cases when you have poor buccal inclination. Now I will show you another technique, how to avoid cementation in such cases, again with poor inclination, because look, this is going too labially. So this is indicated for cemented crown. But if you want to avoid cementation, you can go for another technique, which is the angled screwdriver. The angled screwdriver, it's done by some companies. Even though the implant is going too labially, the long axis of the implant is going too labially, but you can come with an angle with this screwdriver. This screwdriver has a ball in the end, so it can reach the screw from the side, from the palatal side. So the hole can be made palatally, even though the inclination is too labially. And as you see in this case, the hole is on the palatal side, not on the labial side, where it should be, and you have good aesthetic result. No holes anymore. So this is another technique to avoid cementation in such cases. Now, see this case, interesting case. She came to me, old lady. She had a bridge here on 2 implants for, I don't know, 15, 20 years, or I don't know. Afterwards, 1 implant failed. She went to her dentist, and he made her normal partial denture with a clasp on the lateral incisor. And it was always falling. She was always not satisfied with the denture. The lateral incisor starts to move, to be mobile, and she was totally unsatisfied with it. She came to me, she said, I don't want this partial denture. I don't want any more implants. Do something for me. I said, okay, you know what? You don't want any more implants here and make new bridges. So we have 1 implant, which is nice, which is also integrated, no problems. It's still there, functioning. Why not to use this implant here? Yeah. to avoid using the clasp on the lateral incisor. What I did is I did locator, as you see here, which is kind of attachment on the implant. And I did clasp on the posterior tooth from the other side, so it's not affecting aesthetics. So the locator is replacing the clasp on the lateral incisor. So better retention with better aesthetics. This is the clasp on the other one, but no more clasps on the anterior teeth. And the locator is somewhere here under the denture. You see? Good aesthetics, perfect retention. She's very satisfied. She comes for controls, and she's totally satisfied. Why not to use the implant if it is there? Again, I want to ask you a question, but again, we will not. So I will tell you the answer directly. We have also this case where we have, again, another patient. He had 6 or 5 implants, I'm not sure, for a long time. After long period of like 10, 15 years of having a bridge, 2 or 3 implants failed, and we have 3 remaining implants. What to do? How to help this patient? He doesn't want any more implants. He wants to use only the 3 remaining implants. Again, I go for locators. I put the locators, I put the matrix on the female part on the locator, and I do direct polymerization in the mouth. And this is the overdenture using the locators on the 3 implants. He had diastema, so he wanted to have diastema again. I said, okay, no problem. He came for control. He was very satisfied, and I told him I need to film this to see the good retention of the dentures. Look. Oops, sorry. Maybe you cannot hear the click. Yeah, I removed the sound. If you cannot hear it, but it's doing like click. Yeah, when he puts it and when he takes it out, it's making very nice click. And when he bites, it's not moving at all. So he's very satisfied with the retention and of the overdenture. Okay, so we can also use the implant when we have like 3 remaining. Why not? Another case. This patient has almost the same story as the previous patient. He had 5 to 6 implants before, and now 2 to 3 failed. And we have the third one here is also almost failing, but this is long implant in the bone, so it is still also integrated, and he didn't want to remove it. So he said, do me something without removing this implant and without adding any more implants. I said, okay, I will try. In this case, I can use like you did, like I did before, the locators, but to improve the longevity of this one, I need to connect it with these 2 implants to improve the longevity of this one. So I connect them with bar, and I do bar retained overdenture. You see, he's very satisfied with the retention. Again, you need to improve a little bit the oral hygiene here. He has also bridge on implants in the upper jaw. So he was sent to a dental hygienist for improving the oral hygiene. Yeah, but he's satisfied now with the retention of the overdenture, and we treated his problem. Another case, we have 6 implants in the upper jaw. They are fine. We have 5 in the lower jaw. In the lower jaw, I'm a little bit concerned because this is called like Brennemark bridge. You put them interforaminal, 4 to 6 implants, and then you do distal cantilever. Well, my opinion is try to avoid the distal cantilevers as much as possible. So I always try to add more distally, like the implants, to insert more distally, because they are like on one line, almost going like you see in the upper is okay, but on the lower they are almost like on one line. So you have long cantilevers then, yeah? So I would recommend more distal implantation here to reduce the length of the cantilever, because the cantilever is basically overloading of the implants. You see here, The upper is okay, we have cantilever, but it's not that bad. In the lower, you see we have longer cantilevers. Look from the side, you see the long cantilever that we have here and here. So my advice here is to do more distal implantation to reduce the length of the cantilevers as much as possible. Now, what's the complication here? What's the problem here? The problem here is, again, poor planning. Implants are fine, but not for this mouth. Look, we have pockets here. We have periodontitis, active periodontitis going on, and you put implants for this case. This is bad. You have to treat the periodontitis, extract what is needed to be extracted, treat the pockets, and then go for implantation. Because the bacteria will move from these teeth to the peri-implant tissues and will cause peri-implantitis. By the time we make the prosthesis for this patient, screw retained, fine, he lost his anterior teeth because it was like almost falling. So why not to treat this before making the implants in this case? You see, always try to remove what is unnecessary, to remove all these focal infections before doing the implantation. Look at this case again. They came to me, they had already implants, and look at the lower jaw. Big abscesses, big active periodontitis everywhere. Look, I was making impressions in the upper jaw for the implants, and look in the lower jaw. Probing everywhere, swellings, pus coming out. Look, the swelling here on the first molar. Yeah, and you have implant here, implant here, implant there. The bacteria will move to these implants, will infect them. So this is also bad planning. And look also the anterior implant, how deep it is. This is too deep. Yeah, this is very bad because you have long crown. Yeah, it should be like from the cement to enamel junction, it should be like 2 millimeters. This is too deep. Again, we have another problem with this case. What about this case? What do you think happened? What's the problem here? The problem here is screw fracture, fixating screw fracture of the implant, because, as I told you, it is to do with the connection between teeth and implants. I try as much as possible not to connect teeth to implants because you have two problems. One related to the implant, which is overloading of the implant, as we see here, because of the overloading, the screw fractured. And we have intrusion of the tooth and loosening of the cement because the tooth has the ligament and this implant doesn't have ligament, so it stays stable, and this one moves away, and you have secondary caries, you have intrusion, you have a lot of problems with the tooth. So both fails because of the poor planning, because of the connection. As you see here, the screw is fractured because of the overloading of the implant and the intrusion and the caries, secondary caries, and the problems related to the tooth again. So try as much as possible to avoid connecting teeth to implant. Put another implant here and connect the implants together, but do not connect it with the tooth. You can find in the literature, many articles supporting the connection between teeth and implants with special conditions, but in total, in our school and in the hospital, we try to avoid connecting teeth to implants as much as possible. This happened to my colleague. He sent me the photo. He told me, do you know what type of implants is this one? I said, I don't care about the type of the implant, but mainly I care about, look at the problem, the design. Again, connecting teeth to implant and anterior teeth, where you have like huge mobility. So this is bad planning. Again, failure. Look at these x-rays that we see in our work. Look at the upper jaw. Two implants are holding the whole upper prosthesis. And look at the lower jaw. Two implants in the back, these blade implants, and look at the teeth, two teeth. So this is very bad design. You see, bone resorption around the implants because of the overloading, and secondary caries, periapical lesions, intrusion of the teeth. So always try to avoid connecting teeth to implants as much as possible. Again, poor planning, poor results. Look at this one. Again, let's look at the upper jaw. You see, look at the upper right region. So we have very long span. They tried actually here, what I guess. I made an x-ray for the patient. He needs help now. So I made an x-ray, and you see, he tried to avoid sinus lift, the implantologist. So he put one very distal implant and one very mesial. So it was long span. So you see the implant fractured in the bone because of overloading. So this is very bad design, very bad plan. You need to do sinus lift and put more implants here. This is too much, too long pontic area. Also, the design of the implant is bad. Look at this concavity here. So you see another fracture here in the apex region. In the lower jaw, again, bad design. Look, 2 implants in the back and connected with 3 teeth. You see bone resorption around the implants, which is overloaded. And look at the teeth problems, lesions, caries, intrusion, and all other stuff. So my goal is, I'm almost finishing my presentation. So my main goal from this presentation is basically to try to avoid, whenever possible, connecting teeth to implants. Whenever possible, connect implant to implant, but not teeth to implant. And the final thing is like plan properly, and then you have nice results. Really, almost like 90% of the problems we see is because of the poor planning, more than surgical problems or prosthetic problems. It's like the poor planning leads to the poor results. Finally, I will thank you all for listening and attention. And I will thank the IADS for inviting me for this presentation and webinar. And I will thank Abanob again for the technical support during this webinar. And I'm happy if you have any answers, any questions, sorry, I'm happy to answer your questions. Thank you.
Thank you very much, Dr. Basel, for the informative webinar. Actually, we have received a bunch of questions and comments over here. You can see. Okay, you can read them. The first is from Okay, you can read the question.
Okay. So the first one is, what are the indications for bone augmentation? When we need to do it and when not to? Well, this is very big question. So basically, bone augmentation is, again, always, it's good to do the 3D X-ray, the 3D, which is the CBCT, the cone beam computed tomography. It's good to basically do it before the implantation. So accordingly, you will measure how the width of the bone and the length of the bone. And accordingly, you will see, depending on how much bone is there, if there is need for augmentation or not. So let's take example, for example, I have first molar, missing one first molar, like one of these cases that we had before. I'm planning, for example, my implant to have, let's say, 5 millimeters diameter, 4.5 or 5 millimeters. So always you need at least 1 millimeter palatally or lingually, and we need 1.5 to 2 millimeters buccally. It means if it is 5 millimeter implant, I need, as I said, minimum 1 millimeter palatally, so this is 6 now, and 2 millimeters, 1.5 to 2, so you need like something like 8 millimeters bucco-lingual. Okay, so if you have less, then you need to do augmentation. Length, again, this is horizontal augmentation. Vertical augmentation, depending on the length of the bone. If you see that you have, for example, you can use, of course, short implants. This is another like alternative for treatment. You have implants, for example, 5 or 6 millimeters, like long. This is like short implants. I don't do them much. I prefer the classical implants, but you can. Some people, they use it like short implants. Okay, but usually, for example, let's say we are putting 10 millimeter implant, 10 millimeter long. So in the lower jaw, it's lower 6, you have the mandibular canal. So basically, you need to be away from the canal at least 2 millimeters. So you need 12 millimeter of length in that area for your 10 millimeter implant, if you got my point. For the augmentation, it's like very long talk, because you have millions of augmentation materials. You have the synthetic bone grafts. You have the autogenic. You can take like blocks. You can take like granules from the patient, and so really like it's a big issue. You can also, for the membranes, you have resorbable membranes, non-resorbable membranes, titanium reinforced, and etc. So this is the first question, I guess. As I told you, it's very like broad question, so it's very difficult to answer. But I hope that I answered somehow. Yeah, the second one, distal cantilever is contraindicated in all implants or at stress bearing area. Well, for the distal cantilever, you can see sometimes the design like is called, for example, Olomouc 4 technique. In Olomouc 4 technique or a Brennemark technique, you have distal cantilevers. But as I told you, the ideal way that we do in our clinics or in the hospital, or how we teach the students, is to reduce them as much as possible. Yeah, and mainly in the stress-bearing area, as you said, which is basically the posterior regions. For example, if you make it in the lateral incisor region or in the lower incisor region, you make cantilevers, it's no problem, because there's no much stress in that area. But in the posterior area, it is not much recommended. So this is the second question. Third one, I cannot see. Where? Immediate loading. What are the indications to do immediate loading? Yeah, for immediate loading, well, to be honest, I don't do immediate loading. We try to do it always like the classical way, and we leave for example, with some provisional restorations like adhesive bridges or some these of Essex appliances or something like this. I don't do it, to be honest, like immediate load. But you usually do it in certain cases, certain indications. I would do it mainly, if I would do it, I would do it in the anterior region. And I would do it, of course, with provisional restorations, not directly with definitive restorations. And I would do it in the areas where you have no augmentation material or membranes or other stuff. So, but as I told you, and you need to have good stability of the implant. You need to have the torque, the primary stability at least 35 Newton to centimeter. So there are like many factors that you need to respect when you do the immediate loading. But as I told you, we try to avoid it, and we don't do it in our practice in the clinic or in the hospital. Peri-implantitis is caused by the same bacteria as the periodontitis. Well, I'm not sure if it's exactly like the same, because it's not only one bacteria causing this or that, but there will be for sure some mutual bacteria which will be available in periodontitis and in peri-implantitis. So, and in general, when you have active infection in the patient's mouth, so it should be treated. The hygiene should be improved before going to these complicated procedures, because in way or another, it will affect your implants. So, of course, I'm not sure if it is exactly the same bacteria, but some will be, like mutual groups will be here and there. But as I said, you need to treat these focal infections before going to do implants. And the hygiene should be, of course, improved before going for the implants. Now another question: how long do you wait before loading? 3, 6 months? Or yeah. For the loading protocol, also this is like very you will hear different opinions about the loading protocols. But usually, like the classical way is for the upper jaw to wait 6 months, and for the lower jaw to wait like 3 months. Yeah. So it's something between 3-6 months, depending actually on the quality of the bone. If it is softer bone, during the drilling you can notice, and during you see the stability of your implant later on when you insert it. If you see like you have good quality of the bone, you can load it earlier. When you have good quality, good stability of the implant, you can load it earlier. When you have poor stability of the implant, poor quality of the bone, you need to wait longer. But it is always between 3 and 6 months. And as your colleague also asked, which is something to do with immediate loading, I told you some schools, they do directly immediate loading when you have good stability, more than 35 Newton to centimeters, so you can directly load the implant with a provisional crown. Which implant system is best to start? Okay. Yeah, this is like, I don't know if I'm supposed to say some trade names. Yeah, it's okay. Well, to be honest, I mainly use like we use Astra here in the clinic, but I mean I don't want to make like advertisement here for systems. I think it's good to start with one system. As I told you, I do Astra, but like there are millions of good systems in the world. So depending on where you are working. But I think they are available almost everywhere, like Straumann, Astra, Ankylos, Nobel Biocare, and other stuff. So try to go for one system and learn it properly, and later on you can then choose another one and see what you need. I do like different systems, but mainly, as I told you, it's like the one that I prefer, and I do most of my work with the Astra. All right. Do you have any more, or that's it?
I think so. Okay, I think we have no more questions or comments. Thanks so much, Dr. Basel, for your time and for the amazing presentation. Thanks all for watching. And here are some other things from the viewers. Thanks all for watching our webinar today. And we will have you in the upcoming webinars. See you all.